And jumping right off to our next presentation, we're doing exceptionally well. We're right on schedule. I have the pleasure of introducing Jeanelle King. Jeanelle is a physician assistant in the Cutaneous Oncology program. I have been working with Jeanelle over 10 years. She is a patient advocate, and she's going to be talking today about one of the most common questions that patients have, which is side effects of treatment and how to handle these side effects. Welcome, Jeanelle.
Thank you very much, Dr. Lutsky, and thank you everyone for allowing me to present today. Thank you, AIM, and all of the excellent speakers that we've had before. So today I'm going to be talking about the side effects related to melanoma therapy. Okay, sorry about that. Okay, so again, my name is Jeanelle King, and I'm going to talk about the side effects related to melanoma therapy. So we're going to start off with the quiz. Question number 1, Joe has a melanoma and was started on targeted therapy with 2 medicines named dabrafenib and trametinib by his oncologist because his melanoma has a BRAF mutation. About 10 days into taking therapy, he starts to develop chills and a fever that reaches as high as 102.5 degrees Fahrenheit. What should he do? A, call his primary care physician so he can get a prescription for an antibiotic. B, call his oncology team to stop treatment. Or C, wait until the fever resolves and then call his primary care physician. Question 2, Mary has a melanoma and was started on immunotherapy with a 2-drug regimen of Epilimumab and Nivolumab. And about 4 days after her 3rd cycle of treatment, she began to develop some loose stools that evolved into watery diarrhea up to 6 times a day. What should she do? A, call her gastroenterologist so she can get an appointment that's first available. B, call her oncology team immediately because this may be related to immunotherapy. Or C, wait it out because it's likely that her body's flushing out toxins of the treatment because she didn't have any side effects from the first 2 times. So we'll revisit that, and then hopefully by the end of this talk, you'll have the right answers to those questions. So when we talk about the treatment of melanoma and the therapy of melanoma, it's typically divided into 1 or 2 forms, either immunotherapy, which are intravenous medications, or targeted therapy, which are pills. So one of we're going to first start talking about the pills, and that typically occurs when a patient's melanoma has a BRAF mutation. So I just want to give you a little information about what is a BRAF mutation. So this is a simple illustration of a cell signaling cycle called the MAPK pathway, the MAP kinase pathway. And what it is, it's just a cycle that tells cells to multiply and divide. And it involves the 4 proteins, NRAS, BRAF, MEK, and then ERK. And what happens is that NRAS stimulates BRAF, which then stimulates this protein called MEK, which then stimulates this protein called ERK. And then ERK goes into the nucleus of the cell, which is the powerhouse of the cell, and tells the cell to multiply and divide. The problem is that sometimes one of these proteins, in this case in particular the BRAF protein, is mutated, and it's stuck in the on position, and the cell continues to multiply and divide, and that happens to be a melanoma cell. So what we do is we give these targeted therapies, such as vemurafenib, dabrafenib, and encorafenib, along with a MEK inhibitor called cobimetinib or trametinib or binimetinib, to help stop that melanoma cell proliferation, that melanoma cell growth. And 3 of the main drugs combination, there are 3 FDA-approved combinations for patients whose tumors have the BRAF mutation. The first you can see pair is on the left is dabrafenib and trametinib. The second in the middle is the combination of vemurafenib and cobimetinib, which happened to be the first drugs that were approved. And then the third is encorafenib and binimetinib. Now, although they have the same mechanism of action, you can see that the side effect profile is slightly different for each combination. So, for example, with the dabrafenib and the trametinib, pyrexia, which is also known as fever, occurs in 54% of patients, and it can be quite significant. The second combination, which is the vemurafenib and the cobimetinib, diarrhea can be a big complaint of patients, as well as photosensitivity. And then the third combination, which is the newest combination of encorafenib and binimetinib, fatigue, nausea and vomiting, and arthralgias can be can be some of the difficult side effects for patients that patients experience. So here, we have a picture of one of my patients who actually had the photosensitivity from vemurafenib and cobimetinib. And this particular gentleman, there are two things that I want to illustrate here. One is the photosensitivity. He was cleaning his pool and he didn't realize the time went by and he ended up with a rash like this. And so it's critical, as Dr. Jaime mentioned, sunscreen or sun in any form is imperative when you're using this combination. The second thing that I'd like to mention about this picture is that this gentleman also decided to wait before he contacted the office because he was fearful that we would stop his pills and that he couldn't continue his melanoma treatment. And I would not advise that. If you see something, or if you experience anything, it's best to call sooner than later because it's easier to mitigate some of these problems that come along with therapy. Now, this is a very busy slide. This is, but I just want to show this slide to illustrate that fever, particularly when using dabrafenib and trametinib, can be quite problematic. On the left, this is actually what the pharmaceutical company recommends. You can see here that the fever can get as high as 104 degrees Fahrenheit. And initially, it was recommended that you don't adjust one of the medications until you get a fever of 104. 104 degrees Fahrenheit in an adult is very difficult. I don't think many could even manage 102, 103. On the right is based off of our clinical experience and what we tend to do. A lot of times what we do when patients have a fever is we'll hold both of the medications and we'll wait until the fever resolves, and then we may start at the same dose or we may dose reduce. But it's okay if we do either. It's okay to hold the medication. It's also okay to dose reduce because you'll still get the therapeutic benefit. But what you have to know as a patient is that the fever, the pyrexia that comes along with this particular combination of dabrafenib and trametinib, many times it presents with chills or night sweats, or flu-like symptoms. You can even get hypertension, and it occurs usually within the first month of therapy. And as time goes by, it actually reduces, but it may not completely resolve. And so also I would like to say that if ibuprofen or acetaminophen don't work, sometimes we may have to use corticosteroids so that we can continue therapy. So switching gears, we're going to talk about the second type of therapy and the side effects that come along with that, and that's immunotherapy. The concept of immunotherapy is basically stimulating our body to fight the cancer. Now, before we get into the details of that, I just want to talk about what we mean about the immune system. What do I mean when I talk about the immune system? The immune system is our defense mechanism. It protects our precious organs on the inside from all the germs and all the bugs and even the invaders of melanoma that may come on the inside. And when we talk about the immune system, we typically divide it into an innate or an acquired immunity. Now, the innate immune system is very nonspecific. It's present at birth and it's very rapidly acting, and it's your body's first line of defense. Some of the examples of the innate immune system is our skin. Our skin encases our organs and protects us, protects our lungs, our kidneys, our liver from the outside world. Also, our gag reflex, our cough reflex, our sneeze reflex. You get black pepper in your nose and you automatically want to sneeze it out because your body senses that this doesn't belong and it tries to expel it. Think of a splinter. When we talk about, and the cells that are involved tend to be neutrophils and natural killer cells and macrophages. When we talk about the acquired immune system, this is a more specific type of immune system. It's slower acting and it occurs as a consequence of an encounter with a foreign substance. So think about vaccination, for example. It doesn't necessarily happen immediately. It takes time. You may need to get a series of vaccines for it to benefit, but that vaccine may protect you for decades or even a lifetime. And because the immune system has a memory. Now, when we talk about the cells that are involved with the acquired immune system, we really focus on the T cells. And when we talk about the immunotherapy related to cancer care and related to melanoma therapy, it's really the T cells that are doing the heavy lifting when we talk about treatment. So this is a nice illustration, and I'll walk you through it about how the immune system attacks cancer. And in this particular lecture, we're going to talk about melanoma, of course. So when a tumor, and you see here on the left in red, when a tumor cell is existing in its microenvironment, whether it be the melanoma that has spread to the lung or the liver, it's constantly shedding antigens. And antigens are just little pieces of protein that come off of the tumor cell. I think of it as like dead skin cells. And those antigens are kind of gobbled up by another type of cell called an APC. And those APCs actually present those antigens to a naive T cell, and it tells that naive T cell, hey, this is the guy that you need to look for. So if you see this guy, go out, attack, and kill. And as a result of that, the T cell becomes activated, and then it goes out into the periphery, it kills the tumor, and then the tumor releases its antigens, and that process starts all over again. Okay, but sometimes the cancer cell, melanoma, for example, is very smart. It finds several different ways of evading that natural immune surveillance, natural immune destruction. So one way, for example, is they kind of paralyze the T cell. Or another way is that they obstruct the T cell. Or another way is they actually become invisible. The T cell is floating on by a melanoma cell, and the melanoma cell doesn't recognize that it's something foreign and it won't kill it. So what we do is we use immune checkpoint inhibitors. That's our immunotherapy, and that's how we reactivate these T cells so that they can kill the cancer. And some examples you all may have been, are familiar with are pembrolizumab, Epilimumab, Nivolumab, and atezolizumab, among other types of therapies. And this is just as an example about some of the side effects that occur. You know, when we have the side effects that as a result of the immune system, it's because sometimes the immune system is overstimulated and it attacks the healthy tissues as well as the melanoma. And a lot of those side effects are inflammatory in nature. And so when you read the literature, whether from a pharmaceutical company, you may see the word itis, and that's just a medical suffix that means inflammation. And when we stimulate the immune system, this is just a graph that shows you that it can basically affect any organ system of the body. And you'll see a lot of itis there: thyroiditis, pneumonitis, enterocolitis, as well as some vasculitis. as well as some other side effects, but a lot of them are inflammatory in nature. Most of them are mild to moderate, but they can be life-threatening. And so it's critical that you inform your oncology team when you notice a change from your baseline. Okay, most of them are reversible with corticosteroids, but sometimes we need stronger immunosuppressants. Okay, so this is just a graph that explains all the itis. So dermatitis is just an inflammation of the skin, and you can see here this just breaks down into simpler terms about what the side effects are with regard to the immunotherapy. And with one of the drugs, Epilimumab, you can see this common side effects, which tends to be rash, which is dermatitis or pruritus. But one important side effect that I'd like to highlight is diarrhea or colitis. And what's happening is that the immune system thinks that the normal bacteria in the gut is something foreign, and it attacks the gut. And so many people present with diarrhea, and sometimes it's a relentless diarrhea, and it goes on, and certain medications that you would usually use if you had food poisoning is not going to work. And it's critical that you notify your oncology team about that, because it's very manageable when you mention in the beginning, but if you don't, we have to use stronger immunosuppressants. And then you can see here some of the side effects that occur with PD-1 or PD-L1 inhibitors, such as pembrolizumab or tezolizumab. The colitis and the diarrhea, it's not as common, but you can also see here hepatitis, which is an inflammation of the liver function test, and pneumonitis, which is inflammation of the lungs. So sometimes people are more short of breath, or they may have a cough. And this is a nice graph about the kinetics of the side effects that occur with ipilimumab. On the x-axis, you see time in weeks, and on the y-axis, you see the toxicity. Immunotherapy is quite different from chemotherapy, because chemotherapy, you can almost predict when the blood counts are going to drop. You can see here with immunotherapy, sometimes it's weeks or even months before some of these side effects occur. So even though patients are finished with treatment, the side effects, because the immune system has been stimulated, the side effects can linger or develop still. Now here's an example of a rash that occurred with ipilimumab. In the interest of time, I'm going to advance to the next slide, next few slides. This is another type of rash that occurs, and this is actually vitiligo. This is actually a good thing. And what it is that the immune system is attacking the melanocytes, which are the pigmented cells of the skin. And this is one of my patients in the clinic. You could see this was the darker complexion was her original skin color, but she had a pretty extensive degree of vitiligo that actually all of her skin became the lighter color here. You can see it here on her ring too. This is another gentleman who actually had the T cells were attacking the pigment in his hair, in his eyelashes, and in his hair, and you can see that as well. Okay, so generally, when we talk about the general principles of managing these side effects, as a patient, you should contact your oncology team immediately. And sometimes it depends. If it's very severe, we may contact specialists such as gastroenterologists or the dermatologist or endocrinologist if we develop some of those endocrine side effects that occur. Depending on the degree of the toxicity, and that will be determined by your oncologist and the team, we may hold therapy, or we may hold therapy and give corticosteroids. And the strength of the corticosteroids, such as prednisone, may depend on the degree of the side effect. And sometimes we may have to discontinue treatment altogether because the side effects can be so severe, and restarting therapy could be very dangerous for the patient. But what's important for you to know is to avoid the delays. We need to avoid the delays in recognizing the side effects, and patients need to avoid the delays in reporting the side effects. And this is one of my last slides. This is another type of side effect that can occur. This is kind of an intense picture, but this is another type of side effect that can occur with immunotherapy, and it's called pseudoprogression. Basically, what it is that tumors can get bigger before they get smaller. This was a gentleman who had a pretty extensive melanoma on his back, and you could see this is his baseline. And 12 weeks into treatment, things looked much worse. But really what was happening is that all the T cells went to the melanoma and it made it very inflamed. And then over the course of time, the tumors resolved, the tumors improved. So going back to the question, Joe has a BRAF melanoma, and about 10 days into starting therapy, he started to develop chills and a fever that reached as high as 102.5 degrees Fahrenheit. So what should he do? And the answer to that question is B, call his oncology team to stop his treatment. It's likely from the pills. It's unlikely to be from an infection. So, and what we would do in this particular situation is hold both of the medications. And once his fever resolved, we would restart, maybe even at the same dose, but many times we would dose reduce. And the second question is about Mary. She received a combination of Epilimumab and Nivolumab. And after her third cycle, she developed loose stools, which eventually developed into diarrhea. And so what should she do? One was call her gastroenterologist, B, call her oncology team, or C, wait it out. The answer is definitely not C. You can't wait it out, because it's likely if she waits it out, those six times a day may turn into 10, which turns into 12. And that's a much harder side effect to manage. The gastroenterologist, which is A, is not really the best answer, because the first available was the tip-off, was the clue. You want to address this immediately. So the answer is B, call her oncology team immediately, because this could be related to the immunotherapy. Just because she didn't have the side effects initially doesn't mean that she can't have them. And with that, I'd like to thank you for your attention, and I'm happy to answer any questions.
Thank you, Jeanelle. Thank you very much for your presentation. We will be answering questions towards the end of the presentations today, as was previously mentioned.